to the ExEm podcast. Here's your host, my dad.
Well, today is a very special day on the ExEm podcast. I am very thrilled to have this guest with us today. In fact, when we started this podcast a couple of years ago, I knew this was somebody I absolutely wanted on the podcast, and here we have him in season 3. I have referred many of my clients to him and to his practice. I'm so fascinated by what he is doing in the field of psychology and psychological testing. Today, we're going to discuss his passion for helping others and what got him into the world of mental, emotional, and behavioral health. And then we're going to take a little bit of a deep dive into obsessive compulsive disorder, or OCD, and help unpack a little bit of what that diagnosis means. I am super excited that he was open to being on our podcast. Please welcome neuropsychologist Dr. Josh Magleby.
Well, thank you for having me, for sure. I look forward to talking about what we're going to be talking about today. In terms of myself, so I grew up in Utah, and it took me a long time to kind of figure out what I wanted to do. Eventually, I decided that psychology was the thing that really interested me, and particularly child psychology at the time. And so it took me a while to get my degree. And once I got that, I moved around for that degree. I moved to Maryland for a couple of years. I did a pre-doctoral internship at Johns Hopkins at their School of Medicine. They're at the hospital there. It's called Kennedy Krieger Institute. And got to work with some very well-known and well-thought of neuropsychologists and neurologists and other professionals. And it solidified my interest in neuropsychology. And so I ended up, I stayed and worked for a year in Silver Spring for a neuropsychology practice, and then was able to get the postdoc at the Cleveland Clinic in neuropsychology. Focus was on pediatrics, but I also had about a year of adult neuropsychology. So I got to see a lot of, between that and Kennedy Krieger, I got to see a lot of cases and a lot of individuals that I wouldn't have seen in practice here or in private practice. And so then my first job out of my residency or postdoc was I worked at a community mental health center in Cleveland for a couple of years. And so I got to work with another demographic, which was very helpful in terms of how I just developing my understanding of the brain and the effect of the environment on the brain. And then I met a gentleman who was looking for someone to bring into private practice, and he liked me, I liked him, and so I joined this practice, and now this over time he has become less active in the practice, and it's become essentially my practice. So and this is what I do, Monday through Friday, 9 to 5, usually 8:30 to 6. I'm seeing patients, and I really enjoy what I do. I have crazy days, and I have days that are really slow, but I'm very thankful for what I'm able to do. I have a fabulous wife and 2 great kids who are also very supportive of sometimes my hours being pretty late, and so it was a good career choice, I think, up to this point. And, it's also, I've been afforded the opportunity to meet people like yourself and other therapists and other professionals who just continue to help my understanding of human behavior, of the way the brain works and doesn't work, how families work, et cetera, just to help that grow and continue so that I can, provide the best services I'm able to.
Yeah. I'm fascinated by what you do, and you and I've been able to, over the last several years, work with clients that I've referred to you and work on some different cases. Talk a little bit about what does it mean to be a neuropsychologist? Like, for my listener, like what does that mean? What does the job entail, and what do you do?
So in terms of practice, a neuropsychologist is a licensed clinical psychologist, but who has specialized and has had extra years of training specifically looking at the brain, how the brain works, how the brain doesn't work, and looking at the relationship between that kind of brain and the way it manifests, the behaviors that we see. And so for a long time, neuropsychology was really hospital bound because of the cases that you saw there, whether it was epilepsy or traumatic brain injury or whatever, lead poisoning, whatever it might have been. But over time, neuropsychologists have filtered out into private practice. Essentially, what I do in my practice, I'm all diagnostics. I do only evaluations. I don't do therapy at this point anymore in my career, just because I have so much to do on the evaluation side. And my job really is cheesy as it sounds, and I've told many people this before, but it's like I'm kind of like a detective in that people will often come to me, or they'll bring their kids to me, or they'll bring their spouse to me and say, this is what's going on, and we're wondering about disorder A, B, or C. So people will come to see me, and they oftentimes have questions about what's going on. I do see several or many patients over the course of a year where they already have a diagnosis, and they would like to confirm the diagnosis, or they're wondering, well, could it be this or could it be that instead of? And so one of the things I do is I attempt to validate or invalidate whatever diagnosis someone comes in first, because one of the things I want to make sure of, ultimately my job is to help. My job is to help people, is to go from point A, wherever they're struggling or their loved one is struggling, to point B, where they're doing better. Whether that simply means providing a diagnosis based on evidence I find in an evaluation, or simply providing some advice in terms of, hey, have you considered a holistic physiological evaluation to determine if there's a physical cause of the psychological difficulties, or have you considered getting more sleep? That's a favorite one, because most people don't get enough sleep, and that can exacerbate lots of issues that are there. So that's one of the main jobs I do. Another obviously job that I do is to just try and determine what, if there is a set of symptoms, a set of cognitive or behavioral signs and symptoms that indicate a diagnosis. And for some people, just knowing the reason why they struggled with reading, or why they have difficulty in social interactions, or why they have trouble with anxiety. My job as an evaluator is to help figure that out. And once I do, then I will typically refer patients that I see onto treatment, what treatments that I think make the most sense. And almost always, I'm going to refer them to a therapist, to a behavioral therapist of some kind. I'm typically going to encourage them to modify their sleep, or to look at other aspects of their daily rhythm, like their diet or their screen time, particularly for kids. I oftentimes recommend people go look at getting a physiological evaluation done. I encourage people to read, or to listen to audiobooks, because there's so much out there that people can learn themselves. It doesn't mean that you don't need the help, or you shouldn't seek some support from a professional, but there are lots of things that people can do on their own that can supplement that. Definitely.
Yeah. I think one of the interesting things, and why I've been able to partner with you on so many different client consultation issues, is that I think oftentimes when we're able to just get a better understanding of what is underlying and what might be causing, for example, like somebody's feeling distress in their life, but we don't have the gaps to connect the dots to understand why. And then we recognize they have an anxiety issue, which it just helps them. And that's a very general, case, but it just kind of helps them decompress a little bit to go, okay, I have a better idea of what's going on inside of me and why I might be feeling this way. And I think that's really helpful. And I think the other thing is too, in my years in studying mental health, the presentation of different diagnoses, often they show up very similarly sometimes. And then the way that I would treat maybe one diagnosis versus another is very different. And so some of the things that I think I've done where I've referred to you in getting a better look at maybe what's going on. I remember, for one example, I had a mom that was convinced her son had autism, and he kind of presented that way. And I remember through a battery of diagnostic tests that you did, and you and I discussed, and it ended up being an auditory disorder that you rarely diagnose, but it was a very, very different thing than autism, which was pretty significant in that family's life to understand that, had we gone down the autism road, it would have been a completely different situation. So that's why I think it's really fascinating and important to have that ability to understand what is really kind of going on in the mind. What are some of your thoughts around that?
Well, the best way to treat a problem is to know what the problem is in the first place. So if looking at it from a therapy perspective, when someone comes into your office, you want to, as you build the relationship, obviously, you want to identify what the problem is. And then once you identify what it is, you can't just stop there and go towards hey, do this intervention. The next step is to analyze it. I explain to patients that I see that one of the most important parts of an evaluation is to help to determine what the topography is of the problem, as in what are the myriad of descriptors, the myriad of characteristics of this particular issue that they bring in, because as you sort of alluded to, you don't want to diagnose somebody with something that isn't there. Because if you do, a diagnosis, whether we like it or not, it's a label. And it does stick with people. We have HIPAA and we have other privacy laws in place. But if you were to tell somebody, yeah, I have ADHD, for most people, they're probably going to start thinking, oh, well, this person is impulsive or something like that. When of course that's not just what ADHD is. Or if you tell somebody, or if they find out that you have autism spectrum disorder, certainly in the past, it was people would think, oh, well, this person can't think very well. They have, they're slow in some way, which of course is not the case in most cases. So the better you can identify, or the better I can identify what is going on, or any evaluator, any evaluating psychologist, the better they can identify the disorder, then the treatments. If you think of treatment as treatment is like a path, you point them down the right treatment path. So a good example would be anxiety versus ADHD. And like most things in mental health, very few things are, it's not black or white. You can have, in theory, both ADHD and anxiety, but one of my jobs is to figure out, well, is it this or is it that? Because if it's anxiety, it can present very similarly. It's really hard to pay attention and concentrate and sustain your attention and to sit still and to regulate your behavior if you're anxious. But if you treat that as ADHD, and the frontline treatment, at least from Western medicine, is to start with stimulants, that can make anxiety much worse. So you're really not helping the person. You're actually hindering their ability to, their improvement, whether it's a child or as an adult. So that's why for me, it's so important to, as best I can, get it right. As in, ask the right questions, ask as many questions as I can, do whatever testing is necessary to then make sure that within, as we say, a reasonable degree of scientific certainty, that this is what it is. It's this disorder, and these are the treatment modalities that make the most sense.
Yeah. What are some of your takeaways since the pandemic, COVID, political things are going on, Russia's at war with Ukraine right now? There's just a lot of big macro things happening in the world. From your perspective, what are some of the things that you're noticing because of all of that?
Well, I think that an increase in anxiety is definitely something I've seen in pretty much all populations. And that just goes, that's since the pandemic started, but also with certainly the political fighting between Democrats and Republicans and whomever else in this country, those who want to wear masks, those who don't want to wear masks. There's a lot of anxiety, and that anxiety, that's what fear. So fear leads to anxiety, and that doesn't necessarily manifest as people being scared. A lot of people seem really angry, and so they'll come in and they're having trouble regulating their anger, and really the source of that anger could be anxiety.
That's right.
And so I'm seeing an increase. I definitely have seen an increase in anxiety and anger, an increase in depression. So, and I hate to harp on anxiety, but anxiety for me in my career, and I see, I don't know, about 1,900 to 2,000 patients in my practice every year. It's time and time again that seems to be the source for a lot of what people are experiencing, or at least what they come into my office with. But depression, so, when you feel like there's no escape, when you feel like things are crashing down around you, when your business has to close or you lose your job because of the pandemic or whatever it might be, naturally that's going to start developing some symptoms of depression, whether it's feeling worthless or it's just feeling sad, or all that pressure that you're under, all that stress, just sort of making you feel helpless or leading you to feel helpless. So I definitely have seen, from the emotional behavioral side of human functioning, I've seen an increase in those areas. For kids, I've seen an increase in trouble at school with their learning, particularly because all kids had to go online, and virtual learning. It's, I don't know what your experience has been, Matt, with virtual therapy. Virtual sessions are like when I do occasionally I'll do a virtual feedback session with a patient, or occasionally I'll do a brief evaluation virtually because for a variety of reasons. It's not my favorite modality because you're missing a lot of that. I mean, even though you can see the person, there's still there's an aspect or two of social relating that's missing. For sure. And so if a person has trouble just paying attention, sitting in front of a screen for several hours trying to learn, and they're by themselves, there's no real social interaction. They don't get to turn to their neighbor in the seat next to them and say, boy, this is boring, or something like this, or hey, did you see that show yesterday? And so there's this, if you're not paying attention to what you're being taught, you're not going to learn it. And I think this is particularly the case. We see that with younger kids. So kids in kindergarten, first grade, those kids, I can't believe that they tried to sit in front of a screen and try and learn. I don't know how they did it. And then of course you have adolescents. That's a population that really seemed to be negatively affected by the pandemic because of the loss of social interaction. And I can say for my younger son, so I have a 15-year-old son, that for him, 8th grade was a struggle because of that. And 8th grade is an important period of time, that transitional year for kids, and social, continuing to develop your social relating skills and having successes and failures, that was missing. And I think that has, so that the cognitive and emotional and behavioral impacts of the pandemic have been, we may still not know for a while. They're doing research constantly now on the effects, and certainly none of them were good. Yeah. Unfortunately,
that age range that you were talking about is such a massive, massive change. And a lot of that is so driven by our social circles and connections, and super hard. I mean, my daughter just kind of came in and buzzed through our interview real quick. And, it's funny because at 2 years old, we went into the pandemic when she was 2. And she was one of the most outgoing kids ever. And then now coming out of the pandemic in social situations, she just kind of freezes up. I mean, for almost half her life, she wasn't really around large groups of people by any means. So going to church or going to a restaurant, it's very strange for us because she was just so outgoing, and we can see within a relatively short amount of time, but a long time for her life, that we've been really working hard on that aspect of re-socializing her to not be fearful when there's more people than just her parents around.
Right. I think there's a lot of uncertainty that has come from the last couple of years, and that's not just with the pandemic. That certainly, I would say, plays the major role, but also what's going on now in Ukraine, what's going on in the world in general with, if you look at autocrats or strong men who run certain countries, and the fear that and the uncertainty that seems to cause people in the United States, let alone when you've got the type of angry ranting that goes on between the two major political parties, where there's really, they're not modeling, certainly not for kids and adolescents, what it means to disagree, it's okay to disagree, but how do you disagree in an appropriate way? Or how do you deal with, the fears that come with possible war or increase in war going on in Europe? And so you already are lacking the social interaction because of the pandemic, and then what social interaction you get to sort of experience, which might be on watching the news or watching social media. It's very much vitriolic, and it's very much negative, and it's not very hopeful. And so I go back to that uncertainty, and that uncertainty, I think, is driving a lot of certainly the emotional and behavioral changes that we're seeing.
We were talking a little bit about anxiety, and what I wanted to get into today. I'd love to talk to you a little bit and get a better understanding of what's happening with people who suffer from obsessive compulsive disorder. What is it? What is actually happening to the best of our knowledge, and just get a better understanding of maybe somebody's listening that is maybe struggling with that, or a family member is living with somebody who's struggling with it, so we can kind of better understand maybe what's happening with this diagnosis. Sure.
So OCD is it's in the family of disorders, the obsessive compulsive disorders. It's characterized by two main components. There are the obsessions, or the obsessive thoughts, the intrusive thoughts that can cause anxiety. Certainly they're distressing. They can be, these thoughts can be disgusting. They're negative. Mm-hmm. And what that leads to are the compulsions, which are behaviors or actions that in theory that the person believes will reduce, or has experienced that when they engage in these compulsive behaviors, it reduces that obsessive thinking. Or if they're, for example, thinking that something bad is going to happen, then they engage in counting, and they believe that reduces the likelihood of that happening. Mm-hmm. So you have obsessions, you have compulsions. One of the important things to look at when you look at behavior is it impairing? So we all tend to have obsessions and compulsions, or one or the other, but we tend to not engage in them and for a long period of time each day. It tends to not be impairing to our social functioning or our jobs or our job performance or something like that. When it becomes impairing, that's when it becomes a disorder. Mm-hmm. It involves the frontal lobes of the brain. It involves circuitry, more internal, inside, sort of inside the frontal lobes, and then the kind of courses goes through to the very front part of the frontal lobes, the prefrontal cortex, and then kind of goes back to it. And there's some research that implicates serotonin, that the serotonin system, serotonin is a neurotransmitter. People think of it as the mood neurotransmitter, and that there's some problem with the way the system is functioning. There's not, I can't say that there's unequivocal research, as in there's not an unequivocal answer. There tends to be a genetic component to it. There tends to be there's a more of a controversial theory that it can be caused by like streptococcus. So that's the PANDAS and the PANS model. So yep. There's that evidence is certainly, it's not unequivocal for sure. So but regardless of where it comes from, it can be highly impairing. And I look at disorders like OCD as, again, it involves anxiety, but it's a very specific type of anxiety, or it's anxiety about a very specific situation or a very specific thought or set of thoughts, and then it involves that compulsive behavior that can be quite impairing. So if you're washing your hands, 50 times a day because you have this fear of germs, it's kind of like the system that tells us what to do, that reminds us, hey, when your hands are dirty, you wash your hands, that it's gone out of control. Mm-hmm. And it's very difficult for people to control on their own without any intervention.
Yeah. With OCD, do the obsessions and compulsions both have to show? Do both have to be present to have an OCD diagnosis?
No, it just one or the other,
Yeah.
so you can have just obsessions or just compulsions, which can make it kind of difficult to differentiate between, say, generalized anxiety disorder,
Exactly.
or between even autism spectrum disorder, because there are aspects of obsessional thinking that's more ritualistic in nature that goes along with autism spectrum disorder. In generalized anxiety disorder, it's excessive worrying about lots of different things. But again, you can see how OCD could kind of fit into either one of those. And it's not like people haven't been diagnosed with OCD and autism spectrum disorder before. I mean, I've seen that. I've seen, at least in reports or medical documents that have come to me, I mean, I've seen those diagnosed together. I always question that because, which is it? Can it really be both? Because you can't really treat both. I mean, you can teach somebody how to regulate their anxiety, and maybe that'll be helpful with OCD, but OCD, really is best treated by a specific form of cognitive behavioral therapy, whereas generalized anxiety disorder, you have more flexibility. I would say. So yeah, anyway, so hopefully that answered that.
It does. I think it's important because what I like to do on the podcast is bring awareness and understanding and education to the audience to understand that I think sometimes, as you and I had talked in our pre-interview last week, that we look at OCD kind of like in often ways like that old TV show Monk, where it was like the very stereotypical, this is the model for that. And what I've noticed over the last several years is clients who are suffering from OCD, but they don't see it that way because maybe they don't have some of the behaviors, but it's the obsessive thinking that gets them into a position of distress where they realize, okay, I am not functioning at work or at home or in social situations that this is causing me impairment. And often I've shared this with clients before. I'm like, well, my judgment is you're suffering from OCD. And they're like, what? No, no, you don't get it. I don't have to open the door 30 times before I leave. So I think that was kind of leading that question to help people recognize it's not so simple to break down and going, I have to count so many times before I can leave the house or whatever it may be.
Right. And like I said, I do think that can make the diagnosis more difficult to make, for sure. There's also the issue of insight with OCD, and that is there are people who have obsessional thinking, who realize that these beliefs, whatever this thinking is, aren't true, but they still have to engage in whatever compulsive act, or they just can't control that very well. They have this. It's such a strong need to reduce that anxiety that they, will engage in the compulsion. That insight can be good and it can be very poor, where the person completely believes that if they don't, wash their hands 50 times, that they will develop cancer and die. And to those of us who don't have that kind of obsessional thinking, that it seems like, well, that's so irrational. Why would you think that? But however that developed in that person, whether it was a kind of trial one learning where you have one experience and that just set off that ingrained that particular fear in you, or if it's just kind of a set of experiences that a person focuses on just one aspect of each of those experiences. And now that has developed into this very strong obsession, thinking that every time lightning strikes outside, that it's affecting your molars or something like that. I mean, there are all sorts of strange obsessions and compulsions out there. Yeah. But you got to identify them first, and you got to certainly that differential diagnosis process is really important for OCD.
Yeah. And so that from my perspective, how I understand it, a lot of my clients, when we talk about the compulsion, it's oftentimes to get the anxiety or the obsessive thought to rest. Or I remember one client saying, when I go through the behaviors, that then allows me to have the correct thought. So everything was incorrect until he did the behaviors. So he would have, something swirling continuously in a loop, and then he'd go through the behaviors, and then the loop would correct itself, and then he could go throughout his day. And
Right.
Oftentimes, because I don't have, I probably have some OCD tendencies, but I can't imagine being in that brain frame when you're going through those behaviors and compulsions and then obsessions every day. And part of it is to listeners and maybe family members or parents developing an empathy for understanding, my gosh, I can't imagine living life in an OCD brain. I mean, how important is that?
Well, family support in identifying and treating any type of mental health illness is really important. So switching, this isn't OCD, but the literature on traumatic brain injury, there was a set of studies that was done actually in Ohio at the three of the main children's hospitals here. And what it found was the best predictor of outcome for children who had a traumatic brain injury was family involvement and family support. So I'm not familiar specifically with the OCD literature on that, but it would make sense that if you have an understanding family member, or whether it's a spouse, or if it's parents of a child who has OCD, that's going to, without that support, those symptoms will likely exacerbate. Because the anxiety kicks up. And when that anxiety increases, that person likely will see an increase in their obsessive thinking. And then, of course, you see an increase in compulsive behaviors if they're engaging in those compulsions. And so family support and having empathy, especially for people who just don't know, like you were saying, who don't understand, who haven't experienced that kind of racing thought where it goes and goes and goes, and it keeps you from sleeping, and it keeps you from eating, or it might keep you from getting your homework done, or being able to do your job, because it's not necessarily something you can't see. Right. You can see a compulsion, but not if you don't know what you're looking for. And so it is about developing for family members to develop an understanding, realizing that this isn't a purposeful thing.
Right.
This isn't really a choice thing. And that it is something that can be treated, but it takes time. It takes a lot of effort, even if you're taking, Western medicine along with it.
Yeah. As you were talking, being a trauma-informed therapist, we know somebody who experiences a trauma. It's how they're received moving out of the trauma, how they will be able to reintegrate and move through PTSD. I think that's a really good point. Within almost any situation, whatever diagnosis, the environment that you're in can really help direct which direction somebody might go. And I had a young guy years ago who he did the hand washing things, and my gosh, he would come to my office and his, like, the first couple layers of skin would be off his hands, and he'd be in pain all the time. And, he had family members that didn't understand what was happening. So he
Right.
began to get punished for this. So it was creating a negative loop. He didn't want to do the behavior, but, his thought processes drove him to do it. And then the reinforcement of the negativity just created a whole mess of problems. But I think, his parents and family members, they were scared because he would have these open wounds on his hands, and he'd go into the doctor for infections and all other kinds of things. And this was years and years before COVID, but I can't even imagine being in that circumstance. I think the environment's really important. What are some of your thoughts as you've worked with people who suffer from OCD? What are their best opportunities to be looking to try to do to help them work through some of those debilitating behaviors and thoughts? So
the first thing would be to get a full evaluation done. And I don't say that because of what I do. I mean, as I said, the best way to treat something is to know what it is in the first place. And that's where an evaluation comes in. And sometimes an evaluation can be done by the same person who's going to do the treatment. Mm-hmm. But like a lot of mental health disorders, there's a lot of overlap between OCD and other mental health symptoms. And so you want to determine what it is, first of all. So you go through some kind of comprehensive evaluation. That's step one. Step two would be, okay, well, let's say it's OCD, then knowing what are the treatment options for OCD. So there's on the non-medical side, there is a form of cognitive behavioral therapy, and many therapies are cognitive behavioral in nature, not all of them certainly. And this particular form of cognitive behavioral therapy is known as extinction and response prevention, and it has exposure and response prevention. It has a lot of research behind it to show that it is very helpful with reducing OCD symptoms. It doesn't necessarily mean they go away. It doesn't necessarily mean that if they do go away, that they won't come back again. But part of therapy is to develop skills so that in the future, when you do have a return, if you do have a return of symptoms, you can better handle it yourself without necessarily needing to go back into therapy. Though sometimes you do, and that's okay. That's why we have, that's why we do therapy. Yep. So there's that. So there's that's one of that's the best non-medical treatment that I know of. In terms of medical or physiological, I guess, treatment, it would be medication. So the frontline treatment for OCD is an SSRI, so the medicines that are used for anxiety and are used for depression. Sometimes SSRIs don't work all that well, so they might have to try something like clomipramine, which is a tricyclic antidepressant. So an older medicine has more side effects, but can be more effective. Sometimes people even go on a stronger medicine like an antipsychotic. Medication, Western medicine has its place. What I explain to patients, however, is that go the non-medicine route as much as you can and see how you do. It might be that doing ERP or doing, if there's a trauma basis to it, and so it maybe EMDR would be, could be helpful. Yep. If it's whatever it might be, try and go that route first, because, in theory, talk therapy doesn't have side effects. I mean, yeah, it can bring up some difficult things. So, but it's not like taking a medicine that, that might make you unable to sleep or, might increase your thoughts of self-harm or something like that. Those are two of the main treatments. OCD, like I said, it's been researched a lot. And what has been found is that the combination of both cognitive behavioral therapy, more specifically ERP, and medication, Western medicine, SSRIs, shows a really good efficacy for treatment, for reduction of symptoms. Yeah. Definitely. I also encourage people to, control what you can control. So sometimes making sure that you're getting enough sleep so that your brain is functioning at as best as it possibly can be helpful as you're going through, as you're developing, or as you're working on your treatments. Making sure that you have a full physical to make, to determine if there might be a physiological cause or exacerbation of your symptoms. So and that's obviously not my purview, but, working with somebody who is a specialist, who can determine if there is some kind of biochemical reason that what you may have had maybe, mild OCD symptoms, but now you have severe symptoms because you're not getting enough vitamin D or something like that.
Or drugs and alcohol come into play that I've noticed a lot of times where they exacerbate symptoms, those types of things. I mean, I try to take a look at the HALT system, hungry, angry, lonely, tired. Any of those being elevated can be a part of that. And, as I've worked with clients who suffer from OCD, that distress tolerance is something that, sometimes it's not about winning every battle through the course of the day, but let's maybe try to win one today. Like when we feel that obsession come on, and then we're just going to resist that compulsion in that moment. Now, once we move through that moment, that may be really difficult, and 2 or 3 more come. Okay. We're not looking for perfection. We're looking for progress, but trying to allow those things to win. And I'm glad you mentioned, because, I think a lot of times when working with clients in this situation, we try to reduce as much of the symptoms as possible and allow them to get at least functioning in life in some way that is better than when they came to us. But then taking a look at maybe what is going on underneath it, maybe there is a trauma that needs to be addressed under there. Maybe there's some negative core belief systems that have been, triggered up. Maybe there is some hereditary things that we need to be mindful of. I mean, there's all kinds of different elements that happen in that. And I think that's really, really helpful. How much are you seeing? I think you and I talked about it, and you said for you, it's been about normal, but I think it emerged. We've seen a little bit of an uptick over the last couple of years with people suffering from OCD that I don't want to bring a causation into it, but it's just kind of interesting that we're just noticing more clients coming in that are coming in for OCD type symptoms. Any thoughts about that or anything that you've noticed?
Not anything that I've noticed specifically regarding OCD. Like I said, towards the beginning of today, I've seen an increase in anxiety. And how anxiety manifests in each person can be different. So person A may develop a generalized anxiety disorder, so an anxiety disorder. Person B might develop something more along the lines of OCD, which could be, and this is why mental health is so fascinating, but so frustrating too, is that there might be 20 variables that are playing a role into why that person A developed OCD and person A developed generalized anxiety disorder. And so when there is stress, how the brain handles stress, sometimes it goes back to what it's done before. So sometimes we make weird connections like, well, I was scared, or, this thing frightened me once when I was a kid. And so I counted my fingers for 5 minutes and then it went away. Well, so why not just do that again now that I'm fearful, but yet, it's 5 years later or something like that. So sometimes it can be something as simple as, well, this worked last time, so why not do it again? And then it can become something that is now a habit. And it's something and habits are very difficult to break. And so whether it's anxiety due to all the pandemic or the other stressors, whether there's something that's more physiological that's related to a COVID infection, I have no idea, but there is research being done to look at changes in the brain that have been caused by a COVID infection, or whether it's an environmental pollutant or set of environmental pollutants. I mean, we just don't know enough to say definitively this is why there's been an increase. We can theorize, but theories are, we're not necessarily proving those, and they're difficult to prove. Yeah. And you guys are really on the front lines, therapists are, because people more often than not are going to go right into therapy to say, this is weird, I haven't experienced this before, and what do I do?
Yeah. It definitely has been an interesting time. I'm always fascinated by mental health and psychology, and I think in our current world, it's been a conversation that's been brought to the forefront. We're seeing more and more people, I think, who are more open about talking about their mental health than maybe in the past, and it's become something I think that is more in the forefront of people's minds and being okay having these conversations where maybe in the past you had a therapist, but nobody knew about it, or right. We see more people in pop culture talking about anxiety and mental disorders in that. So I just find it very fascinating because I think it's important. I think it's important we need to have these conversations and have these dialogues because it's a real thing. I've been very open about my experience with anxiety, and up until my 20s really didn't experience anxiety. And then when it hit me, it was like, this is a real thing. It shut me down. So if people are now, they've listened to our conversation and they're interested in finding you, what's the best way that they can do that?
Well, if they were interested in having a conversation about, hey, this is what's, I wonder if you do this, or I wonder if this makes sense. They could call me. There's my email as well. We used to have a website. Our website is under construction at this point, so I can't direct people to a website. The easiest way is to email me or call me. I get people, I'm on Psychology Today's website, so they could go there and they could learn a little bit more about my background, my practice, and who I see. But I'm always up for a phone call. I like to answer questions. whether people come to see me or not, I think I got into mental health because I wanted to help people. And this seemed to be over time, because at some point I wanted to be a physician. At some point I wanted to be a teacher, a kindergarten teacher, actually. But eventually I realized that what seemed to fit my personality and my skills and my potential skills the most was mental health. And like I said, mental health is so fascinating and it's so frustrating at the same time. If I've already talked about the frustration because everything can be overlapped, but it's very fulfilling to go to work with someone and for them to say, I feel better. Yeah. If somebody can leave my office after the feedback session and feel like they have a direction, to feel like they have an answer, then I've definitely done my job. And sometimes I can't do that. But if I can't do that, then I can say, this is the next step. And I empathize with people because I have a family. I have quirks in my, the family, in my life and in how I grew up. Yeah. So, I think that if you can understand, if you can empathize with what people are going through, I think that's what people are looking for. As you had alluded to, it's important for families to be supportive and to understand that this is something that it's not a choice. If you tell somebody it's the way the brain is working right now and it needs to be, it's something that needs to be worked on, and they support you with that, that's how people get better. Yeah.
It's integrative neuropsychology in Fairlawn. I'll put all the information on our podcast, the comments section. Anything else you'd like to share with our audience today? And I do appreciate your time so much, especially on a Saturday afternoon and taking time for me. I appreciate that.
Well, Matt, I appreciate the opportunity. I was flattered you asked me in the first place. And I think that the only thing I would say is that if you feel like nobody's going to understand what you're going through and you don't even know if what you're going through is a thing to tell people, realize that you're not alone, and it is something to talk about with people, to talk about with a professional who can just help you to better understand whether it's something that's okay. It's you're not from Mars. It just is one of those things that you're going through, or it's something to let's look at this and figure out what it is more, and then find the right treatment for you. Don't ever not ask questions.
I think that's good. I think the human experience in feeling like we're not alone or we're not an alien is so important. And so many times people come in my office and intake session, they'll say, you're not going to believe what I've experienced. And I'm in my mind, I'm going, I bet you I will. You're not alone. You're not alone. I feel like that's a really therapeutic position. Well, my friend, I appreciate so much your time. Thank you for spending time with us today. Take care.
Glad to do it. You too.
Dr. Magleby, or Josh, as he insisted I call him, really is an asset to our community and a resource for those who are struggling and possibly not even sure why. All of his information will be put in the liner notes of this episode. I really appreciate him taking the time to come to our show and share his knowledge and give us some more insight into the brain and specifically more about OCD. Thank you for listening and supporting us at Emerge Ministries. Also, if you think you might be a good fit to work with our team at Emerge as a mental health clinician, maybe an intern, or even potential video editor, please check out emerge.org/careers, because it might be just the right next move for you. Well, until next time, or when our Savior comes, God bless.